Hello, everyone. Welcome to the webinar from Streamlining Surgical Coordination in Real Time, How Cone Health Maximized Daily Patient Care. I'm Louis Caesar, Customer Marketing Manager here at LeanTaaS. It is now my pleasure to introduce you to Dr. Matthew Tsuei, President of Central Carolina Surgery and Chair of the Cone Health iQueue Committee, and Rami Karjian, Head of our OR business here at LeanTaaS. And now, Dr. Tsuei, I'll hand things over to you.
Morning, everybody. My name is Matt Tsuei. I'm a general surgeon with Central Carolina Surgery in Greensboro, North Carolina. I'm a general surgeon, still in active practice, but I do have some administrative tasks. I lead a fairly large practice. We do most of our cases at Cone Health. Next slide, please. Cone Health is a 5-hospital system in the center of North Carolina. A lot of operating rooms and procedure rooms, includes endo units as well as radiology and cath lab that requires anesthesia. We coordinate the schedules for those. I will come back later in the session and kind of talk about the work that we've done to try to optimize our resources there. Next slide, please. These are today's learning objectives. Hopefully, as we share our experience, then we'll be able to kind of pique your interest in developing new ways, better ways using technology to kind of help you optimize your resources, your resource utilization, and your operations. So I'm going to turn it over to Rami, who's going to give the first part of the discussion today.
Hello, everybody. Thank you, Dr. Tsuei, and thank you all for joining us. So before Dr. Tsuei brings to life some of these concepts that we're sharing on peri-op operations excellence, I thought I would just share a foundation for the group in terms of some of the key principles behind what he's going to share. You're all familiar with the challenges in an OR. They're complex and interrelated because it is a complex system, almost like each patient is a project that needs to be managed from beginning in the clinic all the way through to PACU, to going to that inpatient bed, to being discharged. We think about it in these 3 buckets. How do you balance supply and demand of the OR rooms? How do you balance supply and demand of the staff? And then how do you create the throughput and the velocity across surgical cases? And when those aren't in balance for the rooms and the staff, you get the problems that are listed here. And when the surgical cases aren't flowing through fast enough, you get the problems on the right-hand side. So if we take those 2 concepts, balancing supply demand in ORs themselves and the staff that support those ORs, and maximizing the throughput of the surgical cases, here's a few of the core things that we believe in order to drive that performance. First, for OR capacity itself, we think about this 2 ways. One is transactional blocks, so blocks that are available in any given month and any given week, and more structural blocks, which are the blocks that you allocate. If I use a completely non-healthcare example, think of this as the difference between day trading, so moving stocks in and out within a day, and portfolio management, where you're setting stocks and bonds over a long period of time. We have transactional blocks, structural blocks. For those transactional blocks, what you're trying to do is to drive early release of those blocks where you know confidently that surgeons won't use them. And that early release, you want it to be 3-4 weeks before the surgery occurs. So you want to get that early release. And then you want to get a targeted reuse of that block on February 25th. Which surgeon is going to most likely be to use that block, and try to nudge them that you have an availability. The opposite of this is, imagine if Uber were to send all of us a text message saying, hey, I have a car in Nashville. I may not want that car. I may not need that car now. Getting flooded with availability that's not targeted actually doesn't help. Quite the opposite. It makes me go blind to it. So we believe in early release of time and then targeted reuse of that time to manage the available blocks that come out. Thinking about having a blocked to open time ratio of 75% to 25% or so, because you obviously don't want everything blocked and you don't want everything in open time. Then more strategically, the structural blocks that you're trying to realign on a quarterly going forward basis, or even more often, number one, what you're trying to do is how do I think about allocating the block to the surgeons and the practices that are most likely to use it, aligned with the strategic priorities that I have as a health system? And then how am I collecting block in big enough chunks so that it'll actually get reused from surgeons and practices where it's not going to hurt the surgeries that they're going to perform? And again, those are complex mathematical equations on who needs more block and is going to use the block aligned to my priorities, and who can I take chunks of time away from where it won't affect the volume that they have. So that's balancing supply demand within an OR context. Now we have to balance that against the staff that I have. And here what we found is we can very accurately, at the 86, 87% level, predict 2 weeks in advance exactly what skills, the number of nurses, the number of anesthesiologists, the scrub techs versus circulating nurses that I'm going to need. So predict that 2 weeks in advance so that you can think better about how the staff then get assigned to that. We know if we assign staff to surgical teams that they're used to working with cases that they have experience in, that the cases are going to go better, the patients are going to go better, and the staff are going to feel better. So if we can predict in advance 2 weeks exactly the needs that I'm going to have day by day, hour by hour, then I can match the staff based on their skill, their experience, their preferences to individual rooms and individual cases, and not having to do that at 5 o'clock the night before on a spreadsheet. So we're balancing supply demand of the OR, we're balancing supply demand of the staff capacity that we have, and then now we need to maximize the throughput of the surgical cases. There again, we rely on mathematical sophistication to do that so that I can forecast the critical drivers and build that into the way I'm scheduling. What's my case volume going to be a month in advance? The case length, which I can get now 80% accurate, plus or minus 15 minutes, and the rooms that I'm going to have running. So forecast those things so I can drive throughput and then improve case readiness and productivity. 2 ways we think about that. One is visibility, and you'll hear Dr. Tsuei in a second talk about real-time visibility day of that's happening to my cases, and how can I then start to adjust the day based on that real-time visibility. And in the same way, visibility to a case dashboard that shows me where I am in terms of my PAT process, where I am in terms of my pre-auth process, in one place so that all the stakeholders across the clinic, scheduling, registration, et cetera, can all see the same thing. And then where can we take key processes, automate the data capture, engage and use different tools like texting, like AI agents doing phone calls with the patients, and then bring more HIE data to the clinicians so that they can be more prepared with the patient that they're going to have. So visibility and automation where we can to make the velocity of the cases flow through. So again, some specific OR examples conceptually that you'll see Dr. Tsuei illustrate of how to balance supply and demand across the ORs, across the staff, and then drive throughput of the surgical cases. We have a set of tools at LeanTaaS to support people doing that. You're going to hear Dr. Tsuei talk about a few of those, especially the one on the far right, that real-time visibility. Dr. Tsuei, I'll stop sharing and turn it over to you.
I am a general surgeon that I work at Cone Health, and part of my job is to help coordinate the block schedules for all of the hospitals and ORs within the Cone Health system. So let me just kind of give you a history of where we're at. I've been here since 2006. When I arrived, the blocks were kind of drawn out on paper, and there was not really a structure for how new surgeons would obtain block. There was no real accountability for block utilization. So for several years, there was just no moves. It was very difficult for anyone to get more time. Everyone was complaining about not having enough time. In 2009, the system brought in a consultant to kind of give us some guidance on this, and we created a surgical services executive committee for each hospital in the system to kind of govern blocks. We created a pathway for holding surgeons accountable for their block time and making block changes. We were in this situation where everyone was complaining, but no one had solutions. The schedulers in our offices were under duress to try to get cases scheduled, and they would call the hospital schedulers, and there'd be a lot of phone calls back and forth. And if someone wasn't at their desk or if someone didn't answer, there'd be post-it notes, reminders, and it was a very inefficient system. And so with the work of the consultants, we were able to kind of develop a system that improved this somewhat, but we didn't really have the technological tools to provide good, transparent data. We were using Excel spreadsheets that were just manually run and then printed and passed out at the monthly meetings. Obviously, this was well before COVID, so we still had meetings in person. So we were headed the right direction, but we didn't have the tools that we needed to make this more transparent and more efficient. So we started searching for a partner to kind of help us reach our goals and to kind of modernize the entire system. So we'll circle back later on this, but what we've been able to do over the last 5 or 6 years is really become more efficient, decrease the amount of manual work that had to be done by our staff, let them kind of work towards the top of their license, doing more of the important tasks. I'll say something later about how we're able to kind of coordinate our vendors, which I know is always a major issue in the operating rooms, and overall increased utilization in the operating rooms, which translates into increased revenue. So again, the consultants helped us kind of set up these executive committees, but we were still using antiquated systems with Excel reports that were run. Again, we had surgeons who were wanting to be engaged, but we were still using kind of antiquated systems to kind of share the data. And when we mapped out the workflow, this is what it looked like. There were multiple stakeholders, multiple pathways of communication that were required to get cases scheduled. And if you ever tried to move cases, then all of these people would have to be contacted again. So it became very obvious that we needed something beyond phone calls or emails and monthly Excel reports. So we searched for a partner who would kind of help us see real-time data, believable data that all the surgeons would trust, all the stakeholders could access. And not only a vendor who would just give us this product, but a partner who with experience in working with operating rooms all over the place, all over the country, and to kind of help us modernize our operation systems. So as we were searching for a partner, we learned about LeanTaaS and their iQueue system, which we adopted about 6 years ago, and has been a real benefit to our system. So our goals were to try to not only improve access to the operating room for the surgeons and our patients, but also to establish a strong, robust governance system for how blocks were allocated and adjusted, kind of streamlining the coordination between office schedulers, the main OR schedulers, all of the stakeholders, staffing, nursing, equipment, SPD, and our vendors, and then try to use the capacity that we had rather than just spending millions and millions of dollars building more operating rooms. Fortunately, we had the system in place before we were hit with the COVID shutdown, and this system allowed us to really kind of change our pathways real time and adjust to the constraints, and uh, con we were able to continue almost all of our capacity during that time. So along with the system, just with case scheduling and block allocation, we were able to enhance the day of surgery. So any of you who might work near the front desk of an operating room on the day of surgery, you can almost guarantee that there will be changes. Nothing ever runs exactly according to schedule. So um, cases may run long, cases cancel, emergencies may get added on, and every time an adjustment happens the to the schedule, then if you do it the way that we were doing it before, the secretary at the front desk or the charge nurse has to call minimum of 6 people. If you have vendors involved, then there's a couple more people that you're calling, or text messaging to try to adjust. So there is a system that I'm going to demonstrate in just a minute that called Real-Time View, that is an app that resides on your phone. It has no PHI, so there's no HIPAA concerns there, but it tracks these changes in real time, and it sends customizable alerts to all of those involved. We've used this extensively with our vendors for orthopedics and spine, and they love it. They don't need phone calls anymore. The system sends them notifications when cases are added on, and they have a way to send notifications back when the equipment is ready to go. So there's a red light, green light system in the real-time view that allows all the other stakeholders to know that the vendor equipment is available. So we're going to try something difficult here. I'm going to switch over to sharing my phone, and I'm going to show the app. So this is the actual app. This is a demo environment. But what this does, it shows all of the cases that are going on today. I'm just going to slowly scroll down. So you can see the status, and you can see, so example, this third case, they just finished a little while ago. Some of these others, this case is closing. This next patient is in the pre-op, and everything's completed. You can customize the notifications based on the user. If you click on it, you can actually see which you can add vendors to that case, and they will receive notifications. If there are any changes, notifications can be sent. There's a feature under the profile where you can highlight which notifications you want. So personally, I want to know when my patient, if a case gets canceled, when pre-op is ready, and when the patient is in the room. If I'm on the other side of the hospital making rounds and they roll into the room with my patient, then I get a notification. I can start heading to the operating room. You can track multiple different sites. I track all of our surgeons across all 5 hospitals where we operate. And so every time there's an adjustment, there's a cancellation or a schedule change, this gets updated and notifications are sent. There's a newer feature, which I think anyone in management will find very useful, is being able to see the staff that are assigned to each room, and even the ones who are assigned for giving breaks. And you can kind of track that through this app as well. This is kind of an exciting newer feature, but yeah, I've had the opportunity to use this for the last several years, and this is the first thing I look at when I walk out of the OR. is kind of what's happening with my next case. And since I manage a big practice, I want to see what our other surgeons are able to get done. So this is called real-time view, and this is a very exciting kind of new feature. Anyone on this webinar who deals with surgeons knows that we can often be a little prickly and sometimes tough to deal with as partners. Surgeons, we want to be able to just show up and have everybody ready and waiting for us. But having this system in place with iQueue and real-time view is has allowed surgeons to become better partners in that they have believable real-time data to understand what the adjustments are to the block. It lets us be agile, where we can make block changes almost every month, and it kind of squashes all of the arguments that used to happen when someone was infringing on your block territory, because everyone sees the same data, and it is constantly updated. And so you can convince a surgeon who is very reluctant to adjust their block. You can convince them that, hey, let's try this for a few months. And then if it's not working, we can put it back or make other adjustments. You can also make recommendations. Hey, you don't need this much time on this day. Maybe this other day where you don't have as much block time, maybe you would be able to utilize that more. It's opened up more open time, more first come, first serve time, or more proactive release time, which allows people to add urgent cases on without running late in the day. So what that's allowed our surgeons to become a little more satisfied with their experience at our health system is to be able to come in from wherever, from the office or wherever we are, and be ready to go with a minimal amount of wait time. You get notifications that your equipment is in the room. If someone is running over and your case is running behind, you have that notification so you don't rush over. You might even have time to finish what you were doing before or even grab a meal. And if you have an urgent case, something's in the emergency room, this lets you find time to fit that in. So what we've been able to do over the last several years is establish these fairly robust surgical service executive committees for each hospital. And we meet on a monthly basis. The committee that I run, the iQueue committee, we crunch the numbers and make recommendations to each of the various sites. And they have the discussion and the vote to make block adjustments. And then along with all of that, our schedulers are much more agile and more productive, been able to find open time without having to rely on a lot of phone calls and post-it notes and email messages, but able to get almost real-time access to open time in the iQuue system. So what this has done, it's saved a lot of labor hours in the day. The same day notifications have been able to cut down on the amount of time that the nurses that are managing the ORs are able to need to put in. The vendors are much easier to keep track of, to coordinate with their cases, and they're the biggest fans of this real-time view because they don't have to rely on phone calls. The health system overall is happy with this system because increased utilization translates to increased revenue, which we've heard drives your margin. So we still have room to grow on this. I don't know that we'll ever reach a perfect state, but we have been able to do a lot over the last several years to kind of streamline the system and to provide more access while maintaining the same amount of operating rooms. We haven't had to build more operating rooms, but been able to increase our overall volume, optimize access, decrease the amount of evening or weekend cases that we're doing. by increasing the efficiency of the scheduling during the regular workday. So as we close, I think most of us will readily admit that healthcare tends to be behind a lot of other industries in our technology and how we run our operations. There's a lot of comparisons to air travel and air logistics, but we're certainly not that sophisticated in healthcare. I mean, we all remember the days of road atlases and maps to try to find our way from one point A to point B. But now we have GPS and we have a lot of things built into our cars. So there's no reason in healthcare that we can't adopt this as well. We can move from the days of post-it notes on the side of your computer screen to real-time notifications and multiple stakeholders being notified at the same time of any changes or adjustments that are being made. All right, at this point, we're going to turn it back over for any questions that you might have.
So to kick us off, Dr. Tsuei, this question will be for you. What were the biggest barriers to adoption, and how did you lead through the change management?
So the biggest barriers probably always going to be kind of aversion to change. Surgeons in general are fairly territorial when it comes to block schedules, and once they figure out how to do something or a pathway, they really don't like change. And a lot of that was driven by a lack of transparency. When the data, the block utilization or the collectible time data was just not readily available, then it was hard to convince someone that the changes were in order. So having ready access to real-time data that was only a day or two old, and everyone had access to the same data. You didn't rely on a person in an office somewhere to put together an Excel sheet. You could pull up your own data, you could pull up everyone else's data and compare, make sure you weren't getting singled out. Then we were able to get past the reluctance to make those block adjustments.
And I do think it's for the group here worth reinforcing that point. So within healthcare, say what you will about different personas' willingness to adopt change. Varies by individual. We can't expect, whether it's surgeons in particular, to drive change in their own behaviors, their own mindsets on data they fundamentally don't believe. And, I don't put this, at the feet of hospital administrators or the hospitals themselves. The data within an EHR on some of the operational data, things like block utilization, et cetera, can be very messy and not clean. And it only takes a few anecdotes where that data has been fundamentally off before you're going to not be able to get people to engage with that data. So having a way of getting the data to be pristine so that, to Dr. Tsui's point, everybody believes it, everybody sees the same data, everybody has access to the same data in the same way, then I think that creates a dramatic change in the openness to people to do things differently when it's the same set of data that everybody sees, that everybody accesses, that they believe in. The second thing I'd emphasize, and Dr. Tsuei, I don't know if you have a perspective on this, is that change also has to be built into the workflows and easy. And one of the things I love about the fact that Dr. Tsuei showed that demonstration live is we can all see it's not hard, it's not complicated. He didn't have to sign in 3 times, navigate to a bunch of different places, and it was there, easy and intuitive to use. So the combination of let's give people a common set of reference data that they believe in and a set of tools that's easy for them to use, and then we start to see adoption and scalability.
Yeah, I mean, I obviously come at it from a surgeon's viewpoint, but I will say our schedulers and from our office, as well as the hospital schedulers, are much happier with this because they can submit requests. There's a feature called Exchange where if you're looking for time for a case that's outside your regular block, if you have a case that you see in the office that you need to squeeze it in sometime in the next few days, rather than calling and begging for time and then the hospital having to call someone else, say, hey, can you give this up? It just finds the open time in the system and it gives you almost an immediate response. Our response time when we submit these out-of-block requests is measured in minutes, not days. And patients can be in the office waiting to get scheduled, and they'll be able to leave the office with the exact surgical date and block time available. So that feature has been a huge work saver for our scheduling staff.
There's a number of questions, Dr. Tsuei, in the Q&A. Let me just try to address the broad concepts, and maybe you can speak to Cone Health. The questions are about, this looks great, but how does it connect into the EMR, and is staff entering this? So what we find is in order for this to work in a way that's scalable, it does have to be connected to the EMR, whether that's Cerner or Epic or a different EMR. That connectivity tends to be easy on a relative basis for the IT teams at the health systems to connect up. There's standard data feeds that we can get from the two EMRs, but it does need to be connected. Dr. Tsuei, there was a specific question about the EMR that you use that this is connected to, and any comments you have about that connectivity.
Sure. This health system is on Epic. The connection seems fairly seamless. Of course, I'm not an IT guy, so that's my perspective on it. Often I get questions about, well, aren't there features in Epic that would duplicate some of this? I don't think that they have the accessibility and the transparency that is built into this system, because reporting out of an EMR is an acquired skill that you have to know how to write the report query. Sometimes you have to submit a request and have someone else write the report for you. And if you want to tweak a parameter and run a different report, then that can take more time. It's somewhere in between the old Excel sheets and the iQueue system, but it's certainly not the same level of sophistication and transparency. If any end user surgeon or manager could log in, and you can search utilization by the last year, you can search it by the last month, you can search it by day of the week. You can tell which room is being utilized best on Mondays, and so you can tweak it to that level very quickly and get real-time reporting. So, yes, it does take the data from the EMR, but this does not duplicate stuff that you can already get in the EMR.
So, going back to the beginning of the implementation, we know that these transitions take a lot of people to be successful. Who are the key stakeholders in the committees and in this process?
I'll jump in first. I was handed the easy task of getting all the surgeons on board, and so it was not easy, but no one was happy with the old way of doing it. No one wanted to hang on to the old way. Everyone knew we needed a way to improve. So showing, we held several large sessions with try to cover as many of the surgical providers as possible to show them how the data was accessible and how it was utilized, introduce the concept of collectible time. So just squeezing out another 15 minutes of time in the day does not really help anybody. But if you can figure out how to squeeze out 2 hours or 2.5 hours, someone else can get a real case done during that time. So showing how all that works and kind of explaining how we all are sharing the same finite pool of resources, and how no one really wants to work at night. No one really wants to work on weekends if possible. That if we all kind of buy into the system, um, then we can kind of get more of those cases done, and kind of raise the satisfaction experience level for everybody, including our patients.
And big picture, like so many other places within the hospitals that you all are in, part of what makes this work is the triad, or how your hospital thinks of it. So it would be very typical to think about the stakeholders aligned with your OR director team, your surgical leads, and your nursing leads. The whatever titles in the organization, et cetera, we find taking the chief of surgery, taking the CNO, taking the OR director, that setting that leadership for these committees, and then the folks that work in those teams, keeping those different functions, different parts of the organization aligned, is critical to getting the scale and the adoption.
What were the key drivers that led to the greater success achieved with staff ORs in your ASCs?
So, ASCs obviously are limited by the acuity and the length of the cases, and the acuity of the patients. So what we were finding is that surgeons would drop into a ASC to do a few cases, and then they'd have to go to the main hospital to do their bigger cases. And so it would leave these gaps. And then there were other people who didn't have block time, who needed to find that time, but were not notified about open time and things like that. So what we're able to do with this system is tighten or right size these blocks into shorter blocks, and provide transparency to people who didn't own block time, to say, hey, there's this time available. And then after a few months of them posting individual cases into those blocks, they would earn block time. And so we've been able to make block adjustments, almost every month or two, when before it would happen just once or twice a year, if that. And so being able to make these adjustments, there's usually not a whole lot of argument once you show the data, someone's utilization and collectible time data. Then he's like, yeah, I don't really use it that much, so fine. But the people are much more willing to give up their time. So we're able to fill up the day more, still have a lot of first come, first serve open time, which people are able to squeeze cases in, during their lunch, between a morning and afternoon office, or end of their day, things like that. So it's really helped us to increase utilization, not just in the outpatient setting, but also on the inpatient side.
And then I'll just build on that, given the question that was just submitted. A lot of what Dr. Tsuei is referencing here was what they find at their main hospitals. The concepts are equally applicable in an ASC, but the complexity level, acuity level is different. At a hospital, we see moving towards about a 75% block, 25% open time. The more effective and efficient that open time exchange capability that you have is, the less you need to have of the block time, and the easier it is to accommodate surgeon fluctuations and people being able to say, I need this time on Thursday afternoon, and being able to get that time on Thursday afternoon. We've seen a lot of systems that have blocked at 90 or 95%. And what that does is two things. It encourages honestly a bit of a hoarding mentality, and it makes it very hard for a surgeon to put something on the schedule, a week or 10 days in advance to meet a patient need. So hope that answers that question. Dr. Tsuei, I saw you nodding. Anything you want to add on that?
Yeah. I mean, I kind of joke that sometimes surgeons think that they inherited their block from their grandfather, and no one else is allowed to have it. But this transparent data kind of helps you get past that. There's a question about kind of the committee structure that we have. The iQueue committee that I chair, there's a representative from each of the major service lines, a surgeon on there, and then it's relatively small committee. One of the OR directors is on there. All we're doing is crunching the numbers and making recommendations. So we don't actually do the block adjustments. We recommend to each of the individual hospital surgical service executive committee what the recommended blocks are. We have a system where we put a low utilizer on a watch list. They get notified that, hey, your utilization's low. They have 3 months to make those numbers better, or they can offer themselves to give it up, or maybe they want a different day. So that's how we do that. There's a question about two providers kind of requesting a block for the next day. So if you're trying to add on something a little more urgent and you're just kind of requesting time from the system, it's not going to assign two people. They're not going to be kind of competing for the same spot. They'll be looking for, the system will find open spot that's long enough to accommodate that case. So it's not that manual of a process that two people are looking at the same exact block. You submit a request, say, I would like to do a case 3 days from now, sometime in the afternoon, and then the system will let you know. It's like getting a dinner reservation through OpenTable. You don't know how many tables are open. You just know that you would like to have dinner on this night.
And there was a related question to that, sort of how far in advance that happens. So what we're doing, we found the sweet spot visibility window is to look out 3 weeks and predict. Sometimes we can do it to 99% level of accuracy, which blocks 3 weeks out are not going to get used. So every morning we're looking, we're saying, okay, 3 weeks from today, which blocks aren't going to get used? And between now and 3 weeks, we then are nudging the surgeons to release that time. And in the same way, when those times are released 3 weeks in advance or earlier or later, we're then sending very targeted messages to the surgeons that we believe are the most likely ones to want that table or that time, and saying, hey, we have some time available. The exception, so imagine, again, this is working exactly like OpenTable. We're nudging people saying, hey, I know you're not going to use that reservation. How about freeing it up so people who want to eat dinner on Wednesday night can do that? And then it's targeting people that we know from past data usage are likely to want that Wednesday night, and saying, hey, a Wednesday night slot just opened up. Would you like it? At the same time, Dr. Tsuei or other surgeons can go and say, hey, I'm looking for a Thursday night reservation. And when one pops up, we'll send it to them so that they don't have to be constantly looking every day to see if Thursday night came up.
So, Dr. Tsuei, looking forward towards the future, it's exciting to think about the next steps. So, how do you see surgical coordination evolving over the next few years, both at Cone Health and across the healthcare industry?
I think every health system is dealing with staffing, but this provides a tool to allow systems that are managing the staffing and their other resources to look a little bit further down the road, rather than always operating in a crisis mode each day, and the managers have to scramble and fill in gaps. This allows you to look a few week or 2, 3 weeks down the road, kind of predict where you're at. So using the math part that I don't understand and AI to kind of help predict, to look at historical trends, and also to kind of predict what's going to be happening in the next few weeks or months, then that allows the health system to kind of allocate resources accordingly. And it also helps you adjust to crises, right? Big crises, like no one predicted the pandemic, but this let us kind of understand what we had going on. We built in a case priority system, what had to be done, what needed to be done quickly, what could wait till the lockdown lifted, things like that. So we were able to adjust on the fly with that. And so I think as this system continues to mature and new features are added, I think that it should make the operations part a little bit more simple.
This concludes today's webinar, Streamlining Surgical Coordination in Real Time, how Cone Health maximized daily patient care. I'd like to thank Dr. Tsuei and Rami Karjian for sharing their knowledge, expertise, and insights with us today. Thank you.